We now come to the part 2 of the series wherein we discuss the principles of management of a soft cataract, one which has a significant amount of nuclear sclerosis. Performing a phaco-chop in a patient with a soft cataract comes with its own challenges. Now, when you're performing a direct chop, what happens is that when you impale into the nucleus, it is so soft that it is rather challenging to be able to get a good hold of the nucleus. Should you manage to get a hold of the central part of the nucleus, then once more dividing it mechanically with the help of a chopper is also challenging, as you can see in this following video. Now here's a patient with a rather soft cataract. The first step that I perform is a good hydrodissection, and now let's move to the direct chop. Whilst attempting to impale and hold on to the nucleus, you will notice how I'm unable to get a firm hold of the nucleus, and also I'm unable to divide the nucleus into two halves easily. The nucleus tends to splay open rather than split open, which makes the breaking down of the nucleus into distinct identifiable fragments often a challenge. I keep rotating the nucleus and try and break the nucleus down and get some area where I create a crack. Unable to do so, now I've created a bulb and I'm trying to hold on to the equator of the nucleus and draw it to the center, after which I plan to subsequently downsize and emulsify it. Having brought out one of the fragments, now I have more space, so I bring up the rest of the nuclear fragments and downsize and emulsify them. In this manner, I was able to get by, but you could see the typical challenges that we do face in these soft cataracts. Let's now come to the management of the even more challenging cases. These are the soft cataracts with some amount of a nuclear sclerosis. This is my technique of choice, and I believe the best method of managing these cataracts. My technique of choice is the direct chop technique. The important considerations while performing a direct chop in these soft cataracts is 1. You do not need a very adequately exposed tip. You need to have only adequate power to be able to impale into the nucleus. And the most important take-home message is you need to have an adequately sized chopper. A chopper that is at least 1.25 millimeters in length, because only then will it be able to mechanically subdivide this soft nucleus. Let's now move to watching the surgery. This is a patient with a soft cataract with, as you can see, a very early nuclear sclerosis. We start with the nucleus management. Note the limited exposure of the phaco tip because you're dealing with a soft cataract. And also note my second instrument here is a chopper of an adequate length. This is a 1.25 millimeter chopper that I'm using in this case. With the phaco power set at about 30% and a vacuum of about 250 millimeters of mercury, I start with the direct chop. I start to impale into the nucleus rather proximally so that when I get to the center and slightly beyond it, I'm at the depth of the nucleus. With the help of the mechanical chopper, which is significantly long, I'm able to divide this very soft cataract into two heminuclei rather easily. Once you get a primary chop, breaking down the nucleus into smaller fragments becomes rather easy. As you can see, we've now managed to divide this rather soft cataract into 4 small emulsifiable fragments, after which each of these fragments is brought up into the phaco-safe zone, that is of the pupil, and emulsified. Here's another patient with a soft cataract with some amount of nuclear sclerosis. The same instrumentation as demonstrated in the previous case. Let's watch how we perform a direct chop here. It's such a soft cataract, I start to impale proximally, bury deep into the center, which I reach pretty quickly, and with the help of a long chopper of 1.25 millimeters, I just bury it into the nucleus and move both instruments apart, resulting in a direct chop. Similarly, the heminuclei are also divided. And therefore, to summarize, when you're dealing with a soft cataract with a soft nucleus with some amount of nuclear sclerosis, the direct chop technique is a foolproof technique provided you have just the right amount of power to impale into the nucleus and long enough a chopper to be able to mechanically divide it once the nucleus has been impaled by the phaco probe. Without needing to change my technique, that is performing the direct chop technique for these soft cataracts, I'm able to achieve the nucleus disassembly, that is breaking down of the nucleus into smaller fragments, with absolute ease by making one small change, that is using a longer chopper. I'd like to add here that even if you were a stop and chop surgeon, these soft cataracts are going to pose a challenge once you need to divide the heminuclei into two fragments. So whilst performing a stop and chop, you could make a groove, get to the depth of the groove, crack it in two halves. But in order to divide the heminuclei into smaller fragments, I would suggest you use a longer chopper. Do notice the ease with which each of these smaller fragments is further broken down just by using the longer chopper. Having broken it down to adequate fragments, I perform a viscofluid exchange and replace the long chopper now for a dialer. I think this is another important point too. You need the chopper only to break down the nucleus into smaller fragments. Once broken down, it's a lot safer to use a dialer to guide the smaller fragments during their emulsification. The direct chop technique is a foolproof technique provided you have just the right amount of power to impale into the nucleus and long enough a chopper to be able to mechanically divide it once the nucleus has been impaled by the phaco probe. With this, we come to the end of the presentation of how to manage soft cataracts with some amount of nuclear sclerosis. I do sincerely hope that you found this video tutorial useful. Thank you.